Okay, picture this. You're in the final, most intense part of your surgical board exams, the oral viva. The pressure's on, a senior consultant is sitting across from you, and they're about to hit you with a complex case. Well, today we're putting you right in that hot seat. We're going to dive deep into a consultant-level surgical exam, focusing on the incidental adrenal mass.
So here's how we're going to break it down. Just like a real exam, we'll start with the case presentation, move through the workup, figure out the diagnosis, lay out the pre-operative plan, walk through the critical steps of the operation itself, and then, super important, we'll cover post-op care and all the potential pitfalls. Ready? Let's get started. All right, deep breath. The exam room is silent. The clock is ticking. For this part, I'll be your examiner. Let's see how you do.
Good morning, candidate. We have a 55-year-old male who has been referred to your clinic. An abdominal ultrasound done for other reasons revealed an incidental finding of a left adrenal mass. Tell me, how do you approach this patient?
Okay, the first question is always the big open-ended one. This is your chance to take control, be systematic, and show them how you think. Now it's your turn. You're the candidate.
Thank you. My approach would be very systematic. I'd start with a comprehensive history and a really focused physical examination. I'm essentially hunting for two main things. First, any signs or symptoms that suggest hormone overproduction, and second, any red flags that might point toward a malignancy.
So, as I'm thinking through the possibilities, my differential diagnosis is pretty broad. I'm splitting it into functioning or hormone-producing tumors and non-functioning tumors. For the functioning ones, I'm thinking about primary hyperaldosteronism, which could cause high blood pressure and low potassium. Then there's Cushing's syndrome with too much cortisol or a pheochromocytoma pumping out catecholamines. But, and this is critical, for the non-functioning masses, my number one concern is adrenocortical cancer, especially if that mass is large.
Based on that differential, I'd order a specific set of initial tests. On the blood work side, I need serum electrolytes to look for low potassium. I do an overnight dexamethasone suppression test and a 24-hour urine collection for cortisol to investigate Cushing's, and of course, urinary catecholamines for a pheochromocytoma. Then for imaging, the absolute gold standard is a dedicated adrenal protocol CT scan with very thin 0.5 centimeter cuts to get a really good look at the mass.
Good, that's a very thorough workup. Now, let's talk specifics. When you get those results back, what findings are going to point you toward one diagnosis over another? What are you actually looking for?
Well, the single most important feature on that CT scan is going to be size. A mass that's bigger than 6 centimeters is highly, highly suspicious for adrenocortical cancer. Now, it's not a 100% rule, but something like 90% of these cancers are that big or bigger when we find them. So size is a massive red flag. Other things like irregular borders, signs of necrosis, or invasion into nearby structures would also make me very concerned about cancer.
And going back to the clinical picture, if this patient has both high blood pressure and, specifically, spontaneous hypokalemia, low potassium without being on diuretics, my suspicion for primary hyperaldosteronism or Conn syndrome goes way, way up. That combination is a classic exam tip, and it really pushes you down a specific diagnostic path.
Now, let's say the workup does confirm hyperaldosteronism, but the CT scan is a little bit fuzzy. Maybe it's unclear if the problem is on one side or it shows changes on both. The next critical step is something called adrenal vein sampling, or AVS. This is an invasive procedure done by interventional radiology where they actually thread catheters into the veins draining each adrenal gland to measure the hormone levels directly from the source. It tells us exactly where the problem is. So during that AVS procedure, we measure both aldosterone and cortisol. The cortisol is just to confirm we're in the right vein. What we're really looking for is the ratio of aldosterone to cortisol. If that ratio is more than 4 times higher on one side compared to the other, that's our answer. It confirms a unilateral, surgically fixable tumor. It's a brilliant way to pinpoint the source of the excess hormone.
Excellent. Let's assume your workup has confirmed a unilateral 4-centimeter aldosterone-producing adenoma. You've made the decision to operate. How do you prepare this patient for the operating room?
The surgical approach we choose really hinges on what we think we're dealing with. For a case like this, a benign, one-sided tumor, the preferred approach is definitely a laparoscopic adrenalectomy. It's minimally invasive. However, if I suspected cancer, say for a large mass over 6 centimeters, I would absolutely perform an open interior adrenalectomy. You have to do this to ensure an en-bloc resection, which means taking out the tumor and all the surrounding tissue in one clean piece to avoid any cancer cells spilling.
And of course, a huge part of this is the informed consent process. I would sit down with the patient and be very clear about the specifics of the procedure, whether we're planning laparoscopic or open. I'd discuss the alternatives, like medical management with drugs, and I'd be very explicit about the risks, including bleeding, infection, potential injury to nearby organs like the spleen or pancreas, and the possibility of a post-operative adrenal crisis.
Very well. The patient is consented and is on the operating table. Walk me through the key steps of a laparoscopic left adrenalectomy.
Okay, so we're in the operating room. First things first, positioning. The patient is placed in the lateral decubitus position, meaning on their side, with the left side facing up. This image shows that positioning perfectly, along with where we'd mark our small incisions or port sites. Getting the patient positioned correctly is absolutely key for getting the exposure we need. We start by creating a pneumoperitoneum. We safely inflate the abdomen with CO2 gas to create our working space. Then we place our ports. The first major step inside is to mobilize the spleen medially, which lets it just fall away and opens up the space behind it. Then we can identify the adrenal gland. Now, the most critical step of the whole operation is to carefully find, clip, and divide the main adrenal vein first. This cuts off the blood supply and, more importantly, prevents a massive hormonal surge when we start handling the gland. After that, we carefully dissect the gland free and place it in a retrieval bag to remove it.
You know, this image here really drives home why this is such a delicate operation. On the left side, we are working right next to the kidney, the pancreas, and the spleen. It's crowded in there. So meticulous, careful dissection is absolutely essential to avoid injuring any of these vital structures.
And I just want to emphasize, if this were a cancer operation, there's one principle that would guide every single move I make. The most important predictor of survival for adrenocortical cancer is the adequacy of that first resection. That is why an open approach with wide, clean margins is completely non-negotiable if you suspect malignancy.
Okay, the operation is done, but the exam is not over. Not even close. The final, and you could argue most important questions, are about what happens when things go wrong. The examiner needs to know that you are safe to practice on your own.
Postoperatively, my eyes would be peeled for several major red flags. An acute adrenal crisis or severe hypotension is a big one, especially if we just removed a cortisol-producing tumor. Hemorrhage from the adrenal vein stump is another concern, and finally, any signs of peritonitis, a rigid, tender abdomen, which could signal an injury to the spleen, colon, or pancreas that we didn't see during the operation.
One final question, candidate. It is day 2 post-operation. The nurse calls you, urgently. Your patient has become febrile and hypotensive. What is your immediate concern, and how do you manage it? So, this is the classic viva finale, a true test of your skills as a safe surgeon. The combination of fever and low blood pressure is a surgical emergency, and the examiner wants to hear a clear, logical, and safe plan. The candidate has to immediately consider 2 life-threatening possibilities: septic shock from some kind of intra-abdominal collection or an unrecognized organ injury, or an acute adrenal crisis. The key is to act fast and treat both possibilities at the same time. A great surgeon would immediately start aggressive fluid resuscitation, draw blood cultures, and start broad-spectrum antibiotics to power for sepsis. But, and this is critical, they would simultaneously give a stress dose of IV hydrocortisone to cover for adrenal crisis. If the patient's blood pressure suddenly and dramatically improves after that steroid injection, you've just unmasked and treated an adrenal crisis. And that right there is the kind of clinical thinking that passes the exam.